Why? बुरा पाया वो आ गया
Hello?
Hi, Dr.
Yes, doctor.
Can you hear me?
Yes, sir. Good evening. How are you?
Hi. I'm very fine. Thank you very much. Good evening to all of you, and welcome to. I think if we can get introduction from your team, that will be very nice. Ask them to unmute.
Hello? Yes, I can hear you now.
Can you hear me?
Yes, I can hear you now.
Okay, we just take another 5 minutes and then we start this today's session. Okay.
Yeah, okay.
Everybody should share the video screen, please. And if you want to speak, then please unmute yourself first. Hello, Dr. Nagar, how are you?
I'm fine. How are you?
I'm fine too, thank you. Dr. Nagar, please unmute yourself.
Yes, we can start our discussion today? Can we start?
We will be starting within 5 minutes. Hello, Dr. Anjan, how are you? Anjan Trivedi. You can unmute yourself.
Good evening, sir. I'm fine, sir. Thank you.
Okay. Welcome to today's session, which is like trauma resuscitation and overview. We will be starting within a few minutes, maybe in 2 to 3 minutes.
I don't know no
Participants, right?
don't know no mahot. Amachuani. Kulika bayindi abala. Badokita Pinky. Banapa ani ano sa
Dr. Anjan, could you please introduce yourself? Where are you working and working as? Please unmute yourself and then introduce yourself.
Pardon, sir?
Will you please introduce yourself? Where are you working and you're working as like which specialty?
Good evening, everybody. I'm Dr. Anjan Trivedi. I'm a resident at AFMC Medical College in Pune, India. And I'm presently studying microbiology for my MD degree.
Okay, but you want to learn about trauma.
I don't have an option. I must learn, I must know. And there's so little that I know each time. I recently attended some ATLS course.
Okay,
And
that's nice.
I realized that there's so much lacuna. And of course, it's something additional to my routine work. But then it would be better if I know more.
Yes, definitely. That's a very good point because, like seeing the last pandemic, every doctor can be called to do, any kind of duty. Like even non-clinical doctors were called to do IC duty. So it is better to, when you are a doctor, to equip yourself as many as skill you can. So that's a very good idea, and that's a very good thought. Okay, that's nice. Thank you, Dr. Anjan.
Thank you, sir.
Dr. Sonia, please share your video screen with us. Yeah, she's there. Dr. Sonia, will you please introduce yourself? If you can unmute yourself and tell us something about you. Dr. Sonia, can you hear me?
Hello.
Yes. If you can introduce yourself, just few sentences.
Hello, everyone. Good evening. I am Dr. Sonia, final year emergency resident from Karnataka.
Okay, welcome to the session, Dr. Sonia.
Yes, sir.
Okay. Dr. Nagar, how are you? You are not speaking anything?
Boss, I am okay, good. Nice to see you after a
Okay.
long time.
You are looking smart. Good. As usual.
Thank you, boss. Thank you very much.
Okay. So, Dr. Muwaga,
Yes, please.
we are going to start now the session. So I welcome you all to today's session, that is trauma resuscitation and overview. I'm Dr. Amar from VERVE MEDISIMUHUB. So before we start the actual session, let me talk about the simulation education. Actually, simulation is a very good tool for learning various medical skills, and rather than didactic lecture or theoretical part, so I decided that we will be having simulation in demonstrating various basic life-saving skills also. Because when you see and you see some procedure being done, then you retain more. Secondly, simulation has been a routine in Western curriculum, but in India, it is yet to catch up. We are usually restricted to only theoretical part. So that was my idea, that I should demonstrate. I should not just talk about the theory. I must demonstrate some skill so that you can have some idea, and whenever you want to do those skills, can join any workshop. Okay. So please feel psychologically safe and don't feel apprehensive or nervous or anxious when you are asking any questions or you want to say something. And that's the purpose of this whole exercise, that you should feel psychologically safe. And it's okay to make mistakes. If you make mistakes, everybody make mistakes. And that is the whole purpose of this simulation exercise, that you make mistakes, and in real life, when you are looking after the real patient, then you improve, because ultimately the aim, our aim is to improve the patient safety at all costs. So making mistakes, please don't feel apprehensive, don't feel nervous. It's okay. We routinely make mistakes, but we do learn from our mistakes, and we generally don't repeat those mistakes in the practice. Okay. So these are the points about simulation application. And now, what are the objective of today's session? So our objective will be, like, we will be able to assess and resuscitate a polytrauma patient with life-threatening injury. That's number one. And secondly, we will be performing and learning some basic life skill like surgical crying or ICD, or some advanced technique as well, like EBTM, like endovascular trauma management, something like RIBOA. So these will be our objective. And the third will be transferring these particular skills. Whatever we are learning today, we will transfer that into our clinical practice to improve our patient outcome. So that's the whole purpose of this simulation exercise. Ultimately, we want to do best practice in our clinical medicine and want to have a good positive outcome for our patient by reducing error and by being proficient in our skill. So that's our objective of this today's session. And what are our expectations? I would expect you to be sincere and putting some sincere effort in learning what we are discussing. And it will be in a visual, respectable manner. And don't feel, again, I am saying, please try to be, proactive, ask questions, participate, try to manage the scenario, and that will be definitely fun. And that's the whole point that I am holding this simulation demonstration. Now, coming to the scenario, I think you all know the scenario. I have already put that in the WhatsApp group. So just to be sure that everybody is on the same page, I will repeat the scenario. Dr. Movika, you have the scenario with you, the patient profile?
Yes.
So I will repeat again.
Yes, I have the case. I have the case scenario with me, and I think everybody has gone through it.
Oh, yes, if you can read, that will be nice, so that everybody knows, everybody is like, in what is this discussion. So if you can read the patient scenario, that will be nice. Please go ahead and read it.
Okay. I may not go through it, but we have a 20-year male who didn't have a dial element, and he was knocked. So he had an accident, and the way he presented at the ED was a bit unconscious. So had ENT bleeding, and the BP. Yeah, the BP, he had the BP blood pressure was 100 over 90, pulse rate 120 beats per minute, respiratory rate is 30 beats per minute, and was saturating at 80 on arrival. Maybe you can add on, maybe I missed out something.
Okay. That's the scenario. It's a 20-year-old unhelmeted biker who was traveling on the highway and hit by the truck from behind. And after the accident, he developed hypersensory, developed ENT bleed. He didn't receive any pre-hospital treatment, and he had vomiting also. So he has been brought to your ED department in a private vehicle or on examination. The vitals, as Dr. Moga has told, these are the vitals. Now we can share the vitals with you. And according to vitals, we will anticipate his injury and we will formulate our treatment plan. So these are his vitals. So these are his vitals. He's in hypersensorial, his heart rate is 120 per minute, and that is feeble. His saturation is 80%. His blood pressure is 100/90. Respiratory rate is 30 per minute, and his blood sugar 102. So these are the vitals, and this is a motor vehicle crash. And now we will manage this patient. Now, before we manage the patient, let's do what we know as the preparatory phase or the 0-point survey. In 0-point survey, basically we take stock of our preparation, what we all need to manage these kind of patient. And if you want to remember that, you can remember by the mnemonic step up. Step up means S means self. When you are looking after a sick trauma patient, then you have to be physically fit, morally fit, and spiritually fit to undertake both to be swayed by emotions. And that is number one. S stands for self. Then the T. T is the team. How is your team member? So these are my 10 team members. Come here. And I have assigned them their roles. They know their roles. They know what is expected out of them. So T, as like you have to manage your team. If some member is upset, you take care of him. So the next is the E, is the environment. How is the environment? It is too cold, or it is too hot, or it is too noisy, or like there's some too many attendants and they are rowdy. So you take care of the environment also. And the P is the patient. So whether the patient is coming to you or you are going to the patient. So you have to decide. Step up. Up is like you. You is like you take updates. If the EMT is coming to a hospital, then you take updates from the EMT. What kind of crash he had, what kind of vitals they were having when the crash occurred, and then priority. P is priority. You have to prioritize the treatment, like what we need at the earliest. So after, like we have done our 0-point survey, and these are the things we have arranged for this patient. So so this is the CAT tourniquet, and this is the IOXS. In case if you don't have IV line, this is the ammo bag. This is the pelvic binder. This is the cervical colon. This is our EP sensor, and this is the video scope, the video scope. This is TG tube in case we need to do a surgical try, and various TG tube. And this is a viscoscope. Viscope. This is a new equipment we have bought in airway management. This is viscope. And in case of failed intubation scenario, then we will go for a surgical try. So always keep a plan B. When you are managing patient trauma, always keep a plan B, because otherwise you will have problem and patient might lose his life. So this is our plan B for our failed intubation. Then there are medications and there are lab tubes, then airways, and then we have splint, we have gloves, protective equipment, And in case you don't have pelvic binder, you can have just a plain sheet of, bed sheet. You can buy the pelvic with the sheet also. And these are our iron needles, then various ball pieces, then the suction, and of course the oxygen supply. And now this is a very important part. This is the patient warmer system. This is where has the patient warming system, and this is our ultrasound machine for doing focus. So this is our 0-point survey, and of course we have these pressure bags because we need to sometime rapidly infuse the fluid, and of course O negative blood, and this is blood and fluid warmer. So this is our 0-point survey, and that's what we need to do. Before the patient actually arrives, you need to do 0-point survey, and you should be preparing yourself accordingly. So now we have done our 0-point survey, and now the patient, we will enroll in the patient. This is the molar patient. We have designed and manufactured in India for the first time. All of you can see the molar patient?
Yes, I can see.
Yeah. So this is that gentleman who has been hit by a truck and has been brought to our ED. So he is groaning, you can see. So we will be following the ABCD protocol, and you can see he's groaning, he's in pain, and if we know that his saturation is 80%, there's some issue with his saturation. So I think he's vomiting also, so we'll start suction. So he's doing suction, and at the same time they will be applying oxygen. But we can see there is a bleed here. Can you focus? So this is a like hemorrhage is having. So we need to apply a cat tourniquet here because this can be a catastrophic hemorrhage. So before airway, we need to take care of the catastrophic hemorrhage. Otherwise, the patient will die within 5 or 6 minutes. So he is bleeding, and now Ravikant will show us how to apply a cat tourniquet. So catastrophic hemorrhage has to be tackled at the earliest, even before airway. You can see the blood. Just show them. So he is bleeding. Might be there is a fracture. So first stop the catastrophic hemorrhage even before airways. So they are applying the cat tourniquet, and this is the technique. You pass the tourniquet to the leg, pass the other end through this buckle, and the more important thing is that you apply the windlass. Yes, he is still bleeding. You can see. Show them the floor also. You can see there's a lot of bleeding going on. You can see he's bleeding a lot, and we need to stop this bleed immediately. Otherwise, he can lose his life within 5 minutes. So you need to stop catastrophic hemorrhage before even you manage the airway. But we have a team, so they are managing airway, and he has applied the cat tourniquet, and this is the windlass you have to show. This is a cat tourniquet basically. This is not a simple tourniquet. You must understand. This is a cat tourniquet, and you have to write the timing also. When you apply the tourniquet, you have to write the time also, so that when you are transporting the patient to the hospital, surgeon or whosoever is attending the patient in operation theater knows that this tourniquet has been applied that time, because muscle and nerves cannot sustain trauma more than 4 to 5 hours. So now the bleeding has stopped. We have applied the cat tourniquet. So we have taken care of catastrophic hemorrhage. All right. Now we will come to airway. So his saturation was So now he's doing suction. And since there's a history of vomiting, so they are doing suction, and they have applied oxygen also. It is better to always apply to nasal oxygen, because during intubation also it can prevent your, apneic oxygen. So they are suction, three suction. So they have applied oxygen, and his saturation has come to 85%, but still it is 85%. So now the next step will be to do a BVM and apply a cervical collar. So first you show them how to apply a cervical collar. Just show them how to apply a cervical collar. We will be teaching the system one by one. Otherwise, in a team scenario, everything goes simultaneously. Somebody is doing vascular, putting IV line or IUXS, somebody is applying cervical collar. So we are showing you how to apply a cervical collar. You have to give a stabilization, manual stabilization to the cervical spine, and you have to restrict the movement, and then you apply the other part. So this is how you apply a cervical collar. And then, because the saturation is not coming up with usual oxygen, so our next step in airway management will be to start BVM. So then we will start BVM, and actually it has to be a 2% process, and the one should apply a CE grip. This is the C and this is the E. So during BVM, and you must master this technique, because if everything fails, even BVM will save you from any catastrophic event. So you must master, you must practice BVM multiple times, deliberate practice of BVM through rescue technique, because the seal has to be proper, then only you will be able to deliver oxygen. Okay, with BVM, his saturation has come up to 90%. Now, what will be your next step? Dr. Muwaga, if you can tell me, with BVM, his saturation has come down to, come up to 90%. So what should we do now?
So when maybe it reaches to 90%, you can still monitor the patient and see how the patient is saturating on using that MBVA, that bag valve mask. So you can still continue using that as you proceed to see other parameters.
Okay, I didn't get that. I'm asking you, what will be your next step? With BVM, his saturation has come to 90%. What should we do next? What should be our next intervention? Because he had vomiting, we have cleaned the secretions, we have started the oxygen, now we have started the BVM. But how long we do the BVM? So we need to have some kind of, definite airway for this patient.
Intubating.
So we will go for intubation, right?
Maybe.
So we will go for intubation, because we cannot do BVM for hours together. So for this patient, we will go for intubation. So we'll show you how to intubate a patient in case of, when patient is constantly vomiting. So Ravi will show us how to intubate. So these are our supplies. So we will show you how to intubate when patient is vomiting continuously. So us. You can see the patient is vomiting, and we will try to visualize the vocal cord. Try to visualize the vocal cord. So this is known as down airways, when you are not able to see the vocal cord because of the vomiting or because of the continuous bleeding. Can you see vocal cord? So like he is not able to see because of the continuous vomiting starts. So in such scenario, when you are not able to intubate because of the vomitus and because of the bleed, and patient again starting desaturating, so 90% his saturation has come down by 80%, then it is a like round airway, and again try. We try again to in such scenario, we will do a surgical try, surgical hypothyroidectomy. So now I will, because patient is having continuous vomiting and his saturation is going down, so we will do a surgical try on this patient. So I will demonstrate the procedure for doing a surgical try. So now I will demonstrate how to do a surgical try in case of round airways. So now, Dr. Muwaga, I am demonstrating how to do a surgical try. Have you seen that procedure before, Muwaga?
No.
Okay. So when you are not able to intubate, when it's a CICU scenario, you cannot intubate, you cannot oxygenate, then definitely maybe it could be because of the lot of vomiting, because of the airway issues, because of the anatomy. Then you have to do a surgical try, and this is the procedure I am going to demonstrate to you on our mannequin. So first, this is basically first you do a laryngeal handshake, and you try to palpate the larynx. So I am feeling and palpating the larynx, and then with these 3 fingers, you sterilize the larynx and feel the cricothyroid space. So I am feeling the cricothyroid space, and then you give approximately 1 inch long incision. Cutting the skin and the surface tissue. And again you give the cricothyroid space. And then you try to separate. Although when you do it real for you, I am demonstrating like this is the cricothyroid membrane. Can you see the membrane?
Please stop the mic. Someone getting disturbance. Sir, there is a background disturbance.
Okay, that's we go on, Dr. Nagar. Don't pay any attention to that.
Yes. Okay. Hello.
So after cutting the skin and the surface tissue, you can see this is the membrane, white membrane. Can you see, Dr. Muwaga?
Yes, I can see. So this is the membrane we have to cut open. But in real life, you will not be able to see the membrane because there will be a lot of bleeding. So now we will cut the membrane. We tap the membrane and dilate with the cali, or we can dilate with the finger also.
I will dilate with the finger. And then we will pass the boozy. And you don't need the space. You don't need the running. And over the boozy. You pass number 6 tracheostomy tube. Now we will remove the boozy and we will try to confirm whether we have placed the tube, tracheostomy tube, right or wrong. So we will inflate it. So you can see the lungs are inflating, so that means it has gone into the right space. So this is how you do a surgical cry when you have a failed intubation. So this is the life-saving measure. So after that, we have done the surgical cry, we attach the patient to the ventilator, right? And then we do rest of the treatment. So we have managed his airway. Now next we will manage his breathing. Okay. So now coming back to our molar patient, because his respiratory rate is 30. Okay. So actually so if you see on his chest, because his breathing was 30 per minute and he had low saturation, 80%. So if you can see, there is a abrasion on his chest. Can you see? Dr. Huai,
Yes.
can you unmute yourself and tell us? Huai? Dr. Anjan, can you see? There is a abrasion. So like there is a abrasion and there might be something underlying. So if we palpate, which one? So if we palpate, so there are this fracture over here. We can see crepitation. Okay. So in trauma, you have to be biased. Either patient, because of the rib fracture, could be having pneumothorax or pneumothorax. So what is the way to confirm that? You do an ultrasound, okay, or you do a chest X-ray. So we have a ultrasound facility. So we'll do just in focus to confirm whether the patient has got a pneumothorax or a hemothorax. So he is doing a focus on our molar patient, and what we see here, you can see focus. So if you see, this is the liver and this is the diaphragm, and there is a fluid collection. So you can see there is a fluid collection over the diaphragm. That means this patient has got right pneumothorax. Can you see? So now, because the patient has got a breathing problem because of multiple rib fracture and there is a pneumothorax. But suppose, give me that file. You don't have a ultrasound facility file, and you do an X-ray, and if we find and if you find this is on his X-ray, so what do you see? Can anybody tell me? Is there anything on his X-ray on the right side?
Obliteration of the CP angle, sir.
Yes. So there is obliteration of the right CP angle. That means in a patient or trauma, he has got pneumothorax. Okay. So now our plan will be to put a chest tube. So now I will demonstrate how to put a chest tube in a patient of trauma who has got a pneumothorax. But our mannequin is for pneumothorax. So for a moment, please consider the case scenario for a pneumothorax. although this patient has got a pneumothorax. Now I will demonstrate how to do ICD insertion in a mannequin. So this is our mannequin. This is designed by me, and we are producing these mannequins in India, and they are being used all over India. Okay, so basically the indication for when you do any procedure, you have to find the indication. So for indication in this patient is pneumothorax. Okay, so we will be counting, we will be going in the 5th intercostal space. And how do we count the ribs? You start with the sternal angle, and the space, the second rib will be the second intercostal space. So this will be 3rd, this will be 4th, and this will be 5th. So I will be going in the 5th intercostal space, just anterior to mid-axillary line. So that will be my point of insertion. 5th intercostal space, just anterior to mid-axillary line. Okay, and don't forget to give a big incision, approximately 1 inch. People give very small incision, like 1 centimeter. Then they have a problem when you do the finger sweep. So always give a approximately inch and a half incision, cutting the skin and the subcutaneous tissue. So, and of course, if the patient is conscious, our patient is on ventilator, so we can just go ahead. Otherwise, you need to give him local. So I just give approximately just anterior to mid-axillary line in the safety triangle. I think you know about the safety triangle. Just at the upper border of the lower rib in the 5th space. Cutting the skin and the subcutaneous tissue. Then take the cavity, dilate, dissect and dilate, dissect and dilate. And then you open the cavity and dissect in all directions. Then you clamp it, introduce and do the pleural puncture, and then you get it, give a feeling. And then you open the cavity and bring it out in the open space only, so that you have it wide opening. And now you do the finger sweep and feel inflation of deflation of the lung, like I am feeling, because our mannequin is attached to the ventilator simulator. So this is our ventilator simulator. So this is causing inflation and deflation of the lung. So that's the point when you are sure that you are in the right space. You must feel inflation and deflation of the lung, and then only you should insert the chest tube. Now, when you insert the chest tube, you take it a big caliper, big clamp, not a small one, and the tip of the chest tube should act as a guide, right? And you hold it like this, never like this, because when you insert inside, you can just unlock it, and the whole procedure will be too tight. So you clamp with a big cavity, and the chest tube should be acting as your guiding point, not the cavity, because then you can damage the lung. So your chest tube should act as a guiding point, and hold it like this, and then you give a support also, and insert approximately, like I have given this much of finger, like you can insert this much so that you are safe without damaging the lung. You can cut this much of length inside. So I will be just going inside, and then you release the cavity and insert. How much you have to insert? At least the last eye, the eye is the hole in the chest tube. So the last eye you hold, and 2 centimeters more you have to insert the chest tube, and then you connect the chest tube with the underwater sweep drainage. Because we are discussing a patient of pneumothorax, then you have to, you can see the air is rushing out, so that means your chest tube is in the right place. So this is how you put a chest tube, an interactive chest tube in a mannequin, and this mannequin has got ventilator simulator, it has got duct also. So this mannequin has a certain advantage that you feel inflation of the lung also. So that way you can avoid injury to the lung. This is a very important point when you are inserting the chest tube. Okay, so now we have managed with breathing by putting the chest tube. So now the next system we are going to take care of is the circulation. As the initial blood pressure was 100/90 and it was in narrow pulse pressure, that means is bleeding inside. Okay, so we have, since we are discussing system wise, so now go to that side. Go to that side. So if I ask them to put two large IV lines, to move it, you need to move it.
But I can't find vein.
So, no problem. So now the scenario is that you have no veins. This patient is very obese. There are no veins available. So what is the alternative when the patient is collapsing? So you have to go for IO access. So this is also I have designed image for the first time and for the real patient also. So you can do IO access at the proximal end of the tibia. So now, since there are no IV line vein available, then I will do a IO access in this patient. So I will demonstrate how to do an IO access. So basically, you have to also approximately 1 to 2 centimeters below the tibial tuberosity, right? And you have to go into perpendicular manner. And apply slight gentle pressure, just go inside. And when you give a feeling, stop there. That means you have reached the cortex and gone inside the bone marrow. Then you fix the needle. Fix the needle with a fixer, and then you can and you try to aspirate. So you can see the blood. So that means you are in the bone marrow cavity, and through this you can start fluid because this patient was in shock. So we can start even O negative blood also start fluid. And when you use IO, then you have to use some kind of pressure system also, like this one. So when you do IO access, you don't have to use simple IV fluid, IV water. You have to use a pressure system. So because this patient doesn't have vein available, so we have to do an IO, and we are performing IO in real patient also. And the second place, it's not like in a sick trauma patient, you can put two IO also. One in the tibia and second in the humerus. So when you do in the humerus, then you just feel the surgical neck with gap below just the humeral head and go approximately 45 degrees towards the right hip. So immediately when you get give a feeling, you stop there, and you can put two IO also, not only one. And whenever patient gets stabilized, you can replace IO with central line or a rapid infusion catheter. So this is how we manage, vascular access when veins are not available. And this is a very common scenario. We keep on, treating patient, and patient is already sick and not able to manage, we deteriorate more. So the point I am trying to tell is that do IO access. If you don't have if you fail in getting peripheral vascular access, or you are not able to, get a vein, then immediately in sick trauma patient who is in shock, go for IO access. This is a simple life-saving skill, and through this IO, in fact, you can take the center. There. The blood which we have aspirated can be sent for lab also. And you can give blood, you can give fluid, you can give platelet, anything which you give through the IV line, you can give through the IO. We are doing it routinely here. And this is also designed by us, and this is a very simple life-saving skill. Must practice this simple life-saving skill. And of course, this was a trauma bleeding patient. KXA, you have given KXA? Okay, through this now you can give 3XA. Nowadays you have to give 2 grams direct, not 1 gram and then infusion over 8 hours. Straight away you give 2 gram of PXA upfront. Okay. So now after managing the circulation, what else we have to do? His blood pressure has now come up to 110/70 after giving his, I think, 500 ml of distillate, and we have started the blood also. So through the blood warmer, because this patient is in shock, and generally trauma patients who are in shock should get blood on priority basis. So if you don't like, definitely there's no time, so you can start O negative blood. So we have started O negative blood. Now his blood pressure has come to 110/70. Okay, and as you know, that patient is on the ventilator. Now his saturation is 96% and his pulse rate is 100 per minute. And so now he's stabilizing. But after half an hour, sister tells me that his blood pressure is going 80/60. Now that happens quite frequently in trauma patients. So 80/50 means there's something wrong. There's an ongoing bleeding which we have not addressed. And in such patient, the things we should look for bleeding, one was the chest cavity, the peritoneal cavity, retroperineal state, long bones, of course, here apply cat tourniquet, and the pelvis. And I find that his pelvis is unstable. So that may be a reason that why his blood pressure has gone down again. So we will apply a pelvic binder. Now we will demonstrate how to apply a pelvic binder in a patient who is going into shock or having low blood pressure after resuscitation, or he's a transient responder. So you have to apply pelvic binder at greater trochanter, and it has to be binder to skin contact. You don't apply binder over the clothes. So here they are applying the pelvic binder, and the learning point is that you bind the binder, you apply the binder at greater trochanter, and it has to be skin to binder contact, nothing in between. And suppose if you don't have a binder, if you don't have a pelvic binder, then you can also tie a bed sheet. So remove this and demonstrate how to apply a simple bed sheet also you can apply, and it is as effective as a pelvic binder. So if you don't have a pelvic binder, don't worry, you can apply a simple bed sheet also. So this is a very important cause of mortality, pelvic fracture leading to exsanguinating hemorrhages. So this is just a temporizing measure. If the patient responds to this pelvic binder, fine. Otherwise, there is a new technique nowadays that you can do in patient of exsanguinating hemorrhages, and that is like something endovascular trauma management is the application of Ribova. So now we have applied the pelvic binder, but his blood pressure is still hovering around 86 systolic. So there is an ongoing bleed. So we need to stop that bleed. We can stop that bleed by, if we find the cause, by angioembolization. We can do intervention radiology. But first we need to stop his bleed. So in such scenario, when your E-fast is negative and you have a pelvic fracture and patient is bleeding, nowadays in advanced level 1 trauma center, what they do is Ribova. That is, you occlude the aorta, the blood flow to the lower part of the body stops, and your blood pressure comes up, and you take the patient to the operation theater and you do angiogram. So now we will demonstrate how to do a Ribova catheterization in patient of pelvic hemorrhage. So now we will demonstrate. This is a highly advanced technique, at least not available in India, but we have made a mannequin where you can practice Ribova, and I just demonstrate the procedure. Hold on. So this is the same patient. Now this is the mannequin. So we are demonstrating how to apply the Ribova catheter in exsanguinating hemorrhage or pelvic fracture, which has just responded to our resuscitation, but again that's linked to hypotension. So we have already applied a 7 French sheet. You can see this is basically done to the right femoral artery. You have to puncture the artery, ultrasound guided. So you have to be expert in handling ultrasound when you do Ribova. So already we have punctured the right femoral artery and we applied the 7th sheet. You can see, and now we will remove the assembly. And this is the Ribova catheter. So this is basically a tubing and tissue infiltration. So this is the balloon we will going to inflate in the aorta, and there are two ports. One is the balloon port through which we put the saline, and second is the arterial port through which we report the blood pressure. And these are landmarks like 1 centimeter apart, so that you know how much Ribova has got inside. And this is the T tip. This is the pressure tip through which we report the blood pressure. So this is Ribova catheter. This is placed in very high advanced level 1 trauma center, and we have just the mannequin. So through the 7th band sheet and over the protective covering, center the T tip, and then introduce the Ribova. You can see here the catheter is advancing in the aorta. And now this is the balloon we will be inflating. So we have inflated the balloon, and if we push blood from above, you can see the blood will not flow beyond that balloon. You can see the blood coming from the aorta, and the balloon has stopped the bleed. So when you apply Ribova in such patient, then the blood pressure will come up, and then you can take the patient to OR for definite treatment. So this is just a temporary measure. This is not a definite treatment, and this is very highly advanced field, not only in India, but it's routinely done in Western countries. So this is how Ribova is done, and you could see after applying Ribova, the blood was not going downward. And there are other certain indications that you can use Ribova, like in PPH also, you can stop the bleed, and later you can do hysterectomy. So we have managed now the circulation in blood pressure has again come up to 100/70, and we will be shifting him to operation theater. But when we come to D, he is having artery sensorium.
Can I see why to
No, we have told them. So now we have to find out the cause of his artery sensorium. Why is it artery sensorium? So whenever a patient of motor vehicle crash comes and in artery sensorium, then we have to find there must be something wrong with his head. There is a head injury. So when we examine his head, then you can find there is a head injury over here. And his left pupil is dilated. So because of this head injury, he is in artery sensorium. And now the question arises, the GCS. So GCS scoring we have to do when the patient rolls it immediately, because after paralyzing him, GCS will not be reliable. And only thing you should take into consideration is the motor response. You just look for motor response when you are caring for trauma patient and when you are assessing GCS. Okay, so he is in artery sensorium. Rather, he was in artery sensorium because of his head injury. And now you need to contact the neurosurgeon of your hospital, whether you want a CT scan or you want to do intervention right there in emergency department. So we have contacted the neurosurgeon, and he says primarily you need to stabilize his ABC, and then only you can send the patient for CT scan. Please do not send the patient who are unstable for CT scan, because they can collapse there. So first you stabilize their ABC, and then send the patient to CT scan or other intervention. Or good if the CT scan is portable and can come to the patient. So Now we know that the reason for his altered sensorium.
Satisfaction.
Oh yes, I'm sorry, I forgot to show you his X-ray. So this was the X-ray of the pelvis. You can see there are multiple fractures in the pubic rami, and that's why he was bleeding. Dr. Mua, can you see the X-ray? Can you comment on the X-ray? The fracture, can you see? Unmute yourself, Muaga, Huntington. Unmute, please. Unmute, no? Hello, Dr. Jacob. Please unmute yourself, Dr. Muaga. Can you see now the X-ray of the pelvis?
Yes, yes, I can see the X-ray.
Can you see the fractures?
You try to put it closer. Yeah, the fracture, pelvic rami. The fractures, I can see the fractures.
So in this
I can see the fractures. It is an open book. It is an open book injury.
So there actually fracture.
Yes.
That's why he was bleeding. So two X-rays are must for any trauma patient: chest X-ray and the pelvic X-ray. So that was the reason he was bleeding. So now we will explore. Now we'll come to the E, environment and the exposure. Okay. So now we will expose the patient to find out any hidden injury. Dr. Jacob, are you there, or is just your photograph?
Yes, yes.
Dr. Jacob. Okay, okay, fine. So now we will do the overall. Fine, we will support. So at the count of 3,
1, 2, 3.
so just see his back. Is there any hidden injury? So you can see there is a injury in his back, and we need to take care of his injury also. That could be spinal injury. So exposure is very, very important. But at the same time, so put him down. Yes. So, but expose and cover him immediately. Cover him, please. So basically now we have taken care of his ABCDE, right? His see what we had by catastrophic hemorrhage. So we had applied the cat tourniquet, and of course we will do his X-ray. So if we expose his leg, then we can see that he had a fracture. But before that, we have to apply a cat tourniquet, and now we can apply a Weber wire also, bandage. You have to stop the bleed first. Immediately you have to stop bleed, otherwise the patient will lose life in 5 or 6 minutes. So catastrophic hemorrhage has to be stopped immediately. So that's how you apply a cat tourniquet. So now if we summarize, in today we have seen and we have learned in this patient how to apply a cervical collar. That's number 1. And how to do BVM. 2 rescue BVM. You must do 2 rescue BVM. Single rescue BVM will not be effective in patients of trauma who is having low saturation, right? And then we did the silent mannequin, vomiting, patient coordination vomiting, and then we did the surgical cry. Then this patient was having hemothorax. Then we put the chest tube. Then we apply the, now you can take it off. We apply we also learned how to apply a pelvic binder, and then we also learned how to do an IO access. And when patient is bleeding despite our resuscitating efforts, and patient is having pelvic fracture, then how to apply a Rigova. So these are the things we have done today, and that's the way we should manage the patient, starting from A to E: airway, breathing, circulation, disability, and environment and exposure. And if anything else you can talk about, now you can unmute yourself, Dr. Mubarak. Unmute yourself.
Yes.
So if you anybody have any questions, we can discuss those questions.
I have
Yes.
Dr. Anjan, let me ask you, how was the management we demonstrated?
Yes, sir. Pardon, sir, please repeat.
How did you find our exercise, written exercise? Do you think will be helpful for the doctor?
Definitely, sir. It is helpful, and it's a source of revision and new knowledge also. I have one question in my mind too,
Yes, please.
but then it may not be so important to you. I wanted to know, since we are making a direct sinus passage to the bone marrow through that intraosseous needle.
Yes.
So, what complications I would expect? I mean, how long it would take to heal, and how safe would it be from that infection point of view?
Yes, they're basically right. There are chances that one might get infection, but here the scenario is life versus limb, right? So we may sacrifice the limb if we save the life, but as far as the healing is concerned, it heals in 24 hours, right? Once you remove the IO needle, it heals very, very fast, and you can keep, this is the only temporary measure, you can keep it just 24 hours. And by the time your venous pad is filled, then you can go for other, modalities like putting a central line, central catheter, or a rapid infusion catheter, or maybe then you are able to put a IV line also. So definitely this is a concern, like osteomyelitis, it is there, but you have to see the scenario. Scenario is life versus limb. So we will always give priority to the life and then the limb. He might lose the life, but he might lose the limb, but we have to save the life. So that is the way it is. There are some concerns, but definitely it is not as frequent as we expect. We think like osteomyelitis, chances infection, or bone fracture in children. So it's a very safe technique, and possibly it is life saving. So definitely you go.
Sir, plus osteomyelitis is also manageable. It's treatable, so it's not a big issue.
First we have to save life, and rest of the complication can be managed, right? So that should not stop us from using IO access. That's what I'm trying to say. Just fear of infection or fear of maybe fracture in children, although that happens very rare. So that should not prevent us from using IO access, because it is a life-saving skill, and we must use it whenever we are not getting IV line in 2 attempts, or we are not getting IV peripheral access. So we must, because it's a new technique in India. It's not used in India. Our center is using. We are using IO access in real patients. So this is for real patients we have designed, and hopefully we make it widely available, and we will train doctors in this technique, and then they will be much more confident doing it. AFMC we are going to supply. Is there Dr. Jaiswal and Dr. Sir? They are in talk with me, and we are supplying IU access to them. Very soon you will see in AFMC doctors bring IU access. I think in a month or so. So I'm talking to both of the doctors. They are in touch with me, and we will be supplying IO in the AFMC component. and even Indian Armed Forces also, Udhampur, right? In command hospital Lucknow. So they are also in talk with me. Since this is a life-saving technique, they are basically in battlefield injury. It is the blood loss which was loss of life. So applying a cat lubricant and IU access. These are the things we need to have in battlefield. Because you don't have time to put IV line, can't waste 10 minutes fighting a line. Put a IU access, apply a tourniquet whenever there is a executing average of the limb which has been torn apart. These
Right.
things I'm going to, supply to Indian Army also. Oh, very good. There is definitely.
Sir, you have showed. Good evening, sir. First of all, I just missed because I had it.
Yes.
I had a trauma cases just right now. I just came from there. I missed the webinar, but in the IU access, sir, you showed the tibia part, like how to insert it on the tibia. If we have a fracture or some other injury on the leg, then what are the other sites we can use this IU?
I demonstrated in the humerus also. So if you have fracture, then you can insert in the humerus also. You were not there, but you can always just above the surgical, neck, 1 centimeter above in the head, at an angle of 45 degrees, put for the right hip.
Okay, sir.
So in fact, humerus is the preferred site because blood flow in the humerus is up to 30 liters per hour, whereas in tibia it is just 6 to 7 liters. So humerus, if you are expert, is always preferred. Can you share your video with us, Dr. Dilip?
Sir.
So that we can see you.
Sir.
Yes. So there are sites like there's proximal tibia, there's distal tibia, proximal femur, and the humerus and the sternum. So these are the sites where you can perform IU. It's not only the tibia or the proximal part. So you were not there, but I demonstrated IU access in humerus also.
So actually, I was in trauma only. That's why.
Where is your other friend? Is he on duty? Ansh?
Sir, they are on duty only right now. They just finished from there.
Ask permission for the concerned authority to attend these seminars. This is for you people only, right?
We got the authority, but the timing of trauma was that only, sir. It came on at 8 p.m. only when the webinar started. Okay. So we had to be there.
They were knowing that trauma situation is going to help, and let's go and find out how to treat us.
So we got 4 splinter injuries right now, so we manage those.
Okay. So we showed how to apply cat lubricant also.
Yes, sir.
So that's what I was talking about. The combat, the cat lubricant, and the IU access. These are the 2 important things which our armed forces should be using very routinely. Because in armed forces, vascular blood loss is the primary cause of death, and we must prevent that by applying blood loss, by applying the lubricant and replenishing blood with IU access. So these are the 2 things I always emphasize. Of course, I am also in talk with Dr. Arpit. I also talk with Dr. Arpit, and he is also very much interested in IU access. Apart from your command hospital, Udhampur.
Sir.
So basically, we are not on jams. So once we come at jams, then you will get IU access. Now we have IU access to the patient. Yes, Dilip.
How early it can be done, sir? That jam part?
No, we are doing. That's our problem. We are sorting it out.
Sir.
We need to go government marketplace. We are not out yet. So I think it will take another 15 days, and then I think that IU access will 2 months definitely. And that's what I want you to do. You watch our videos and try to practice. We have a mannequin to practice IU access.
Yes, sir. We have a mannequin.
With IU gun, with this power driver.
Sir, can't hear you, sir. We don't have the tools right now, sir. That IU driver we don't have.
So we will supply you training kit also, right?
Sir, fine, sir.
First get trained and then can do on real patient. That's our endeavor.
Yes, sir.
So I'm planning. I'm talking to Dr. Ajay Dabas, Colonel Ajay Dabas. I think in the Amar hospital.
Sir.
So we are planning a workshop there in Udhampur. So there
Okay, sir.
we demonstrate all these skills because these are nice having skills and we need to be experts. I
Sir.
would say perfect, near perfect.
Sir,
Okay,
if possible, come to Srinagar, sir. There is the trauma center, main trauma center of Indian Army.
oh yes, we will. First, let us go to Udhampur because
Sir.
your command hospital is there. From there, I think
Yes, sir.
they will maybe to them we can go to Srinagar. Is it safe to come to Srinagar
Sir.
for us? Or we get traumatized?
No, sir, you will not. We
We
will
won't
take
get
care
any
of
trauma. Hmm?
Sir. Yes, sir.
We won't get any trauma like Srinagar. We will be fully
Right.
protected.
Sir. We will take care of you, sir.
Oh, that is. Thank you very much. So, any other questions, Dr. Pinky? What about government of Haryana? You recommend these skills to government of Haryana for trauma care? अभी मौका मिले तो उनको बताओ कि सर थोड़ा थोड़ा ये भी करवाते रहो, नहीं?
Yes, sir. Sir, how long we can keep Riboa inside body?
Vivoa, yes. We can keep like maximally 60 to 90 minutes. But now, as I talked in the video, people are using partial Riboa, where they are deflating the balloon intermittently. And when you do that, you can keep it longer time. Although exact time is not known, but the maximum time with full drawn balloon is 90 minutes. And by the time you have to take the patient to the hospital and do the test. So at least this is a temporizing measure basically. This is a tool. This is another tool in our kit to manage trauma patient. Temporarily you stop the beat, take the patient to the OR because in Western countries they are already big, so everything is ready. Patient just rolls in and they get to work. So this is temporary, but that's not a very good question. 90 minutes I would say as of now. You can keep the Riboa because they have problem with inner artery, spinal artery, their systemic. So I mean less is the better, but maximum 90 minutes you can keep.
Thank you, sir. It's a very interesting session today. Thank you.
Thank you for attending, Pinky, as always.
Thank
So
you.
if there are no questions, then we can wind up the session and can say bye-bye. Huai, can you hear me? Dr. Huai. Huai. So then we will wind the session and bye-bye. See you next time.
Thank you, sir.
Thank you.
Thank you very much for your time. I hope more people join and can learn something at least.